The subject of today's webinar is whether age, sex, deprivation or travel mode is most important for road injury and fatality in England. And we have an excellent presentation. I'm really looking forward to it. But before Jenny gives her presentation, I'm going to invite Scott to come in and just do the housekeeping and a little bit more information about this series of webinars for us. So I'll just pass over to Scott.
Thank you. Next slide, please. So we are recording, so if you don't want to appear on this, keep your camera off. Keep yourself muted unless you're asking a question. The way that we do questions in these is we do ask people to raise their hand, not in the chat. It just became unmanageable in previous webinars, and please respect everyone. Next slide, please, Jenny. So just about information about our hosts. So we have 3 hosts for these events, for these webinars. The first one is the Transport and Health Science Group. We invite everyone here to join THSG. We are a small charity to share and disseminate knowledge about transport and health to the public and decision makers and campaign for better transport choices. Next slide, please. We're also supported by the NIHR Research Support Service Specialist Centre for Public Health, delivered by Newcastle University and Partners, which is your one-stop shop if you are considering anything to do with public health research. Next slide. And also the NIHR School for Public Health Research, which is a collaboration between the universities, which you can see on the screen there, that have done previous pieces of research around transport and still do so now. Next slide, please, Jenny. Just to highlight, just to quickly make you aware of things, we still have places at the training that Adrian is delivering via THSG next week. This is training which you would normally have to pay for. We've got about 30 places left, so this is open to anyone working in local government in the UK. First come, first served on those last places. And yeah, as I said, I mean, I've done the training before. It is truly excellent, and normally you'd have to pay. This is a freebie, so if you want to come, drop me a line. Next slide, please, Jenny. Next week, a few of us who are doctoral fellows funded by the National Institute for Health and Care Research are doing a webinar on the offer for people working in local authority settings. So if you're at all interested in doing a fully funded pre-doc, doctoral fellowship, PhD, or a postdoc fellowship or a short placement, please come along next week. I'm going to put the link to register in the chat. These fellowships are brilliant. They are fully funded. They cover your salary whilst you're doing your PhD, for example, allowing your employer to release you from your role and backfill you. Yeah, that's me. Pass back to Margaret, please.
That's great. Thank you very much. And particular thanks to Scott, who has pulled together this excellent series of webinars. They've all been really great. And I'm really looking forward to today's presentation, which is from Jenny Mindell, who is Emerita Professor of Public Health at UCL and has worked on transport and health for many years and been really a leading light of the Transport and Health Science Group for many years as well. And I'm really looking forward to hearing what she has to say. Jenny will speak for about 25 or 30 minutes, and then we'll take questions. So please pull all your questions together. Other comments and things can go in the chat, but if I would ask you to save your questions and put up your hand at the end if you can. Jenny, the floor is yours.
Thank you. Not knowing who's here, I'm hoping that you all know about the benefits of active travel, but a very quick summary, and then I'm going to look about some of the problems that there were when comparing mode at the time we started doing this work, giving you some results from some of our studies, and I've put all the references at the end, looking at some other studies I found that other people have done, and then just bring you up to date with some recent road travel injury data for Great Britain and slightly worldwide. There are some slides that I'm not going to show, but they're there so that if anybody wants the slide set afterwards, they're there. So most people know how important physical activity is for health, but not everybody realizes that incorporating walking and cycling into daily life is not only the easiest way to be physically active, it can actually meet all the recommendations for physical activity, which is important when about 1/3 of the adult population in England is insufficiently active. So Active travel to work is as effective as a training program. It can provide the same health benefits as sports and other exercise, increasing cardiorespiratory fitness. And that applies even in active people, where longitudinal studies have shown weight loss on changing from car commuting to active travel or public transport, because most people travel actively at one or both ends of a public transport journey, and also showed weight gain on people who changed to commuting by car from other modes. It's age independent. These are 5-year-olds cycling to school in London. It's affordable. It provides door-to-door access. It doesn't affect other people's air quality. It's flexible. You can go when you want, not with somebody else's timetable. It's beneficial for mental as well as physical health. And even if you're only looking at people who are healthy at baseline, those who travel actively have less sick leave and live longer than those who commute by car. But there are problems with the comparisons of risk or danger by mode. First, there's different coding for pedestrians and cyclists. So in most countries, in Russia, it has to be a motor vehicle, but in most countries, the definition of a road travel injury or incident is involving a vehicle. So if you fall off your bicycle, in the same way as if you crash your car into a tree, nobody else is involved, it counts. If you're a pedestrian walking along the road and you fall over, it doesn't count. Even if you're walking in stupid high heels. Now, if you were dressed the same and you were on your bike and you fell off, that would count. If you were pushing your bicycle across the road, it might. It depends on who took you into hospital and what data were recorded. Secondly, there's a different treatment of location. So if, as I did, you fell off your bike on a mountain bike course, or you were injured while at a velodrome, the chances are that when you got to hospital, the hospital episode statistics would include you, because they often don't do the external coding accurately. The external codes for injuries are about the cause of the injury rather than what type of injury you sustained. And the 4th digit gives location, but that's often missed off. So HES, hospital episode statistics, often overestimates injuries for travel by cycle because it includes non-travel. Police data only includes road travel incidents of which the police are aware or whether it's been notified to them. So many believe it underestimates cycle injuries, which it particularly for more minor injuries, although less so for severe. And as I said, HES overestimates. Now, the main problem is that people compare numbers rather than rates, and numbers are very important if you're planning, for example, hospital care, or if you're trying to prevent the biggest number of deaths or injuries. But when you're making comparisons, you need rates. For our studies, we use the National Travel Survey. That has a limitation that it only includes trips where motor vehicles go, and it omits journeys, for example, on the 5,250 miles of traffic-free paths on the National Cycle Network. Now, in 2022-23, over 4 million people made nearly 600 million journeys by foot or bike on the UK network, although some of that was on places where traffic can go. And later on, we can discuss options for countries without travel data of what they could use as denominator data. There's also no data by age or sex or socioeconomic position of the person affected. There are studies that have looked at the area deprivation of the place at which crashes and injuries have occurred, and those have showed that the more deprived it is, the higher the rates. And when I say there are no data, there weren't any at the time we did this work. So we wanted to make like-for-like comparisons. Cycling is perceived as an unsafe travel mode in many countries, but we wanted to know if fatality rates existed by age, gender and mode. And our first paper also covered hospital admissions, which I'm not going to look at today because of issues of time. and the reference to this is at the end of this presentation. We also provided numbers for hospital admissions and deaths from pedestrian falls, which you can find in supplementary tables of this. The pattern for admissions is very similar to the fatality data I'm going to show you in a moment, except that for admissions, for driving is an order of magnitude lower than for cycling and walking. We then did a second paper where we could do much more accurate denominator data of time spent travelling, and to see whether as road travel deaths have fallen, whether these differences persisted. I'd like to thank my co-authors, Rebel, Malcolm and Sean, and also Sam Dickinson, who provided the National Travel Survey for us. So from the numerator, we used the number of deaths from ONS, mortality data and police data by age, sex and area deprivation of where the person lived for England for these 6 years. Not only we looked at road travel deaths involving any vehicle, but we also included pedestrian falls in the street to make the comparison more like for like, using a specified list of external ICD codes, including the 4th digit for place. And for the denominator, we used National Travel Survey for the same 6 years, again by age, sex, travel mode and area deprivation of the participant. And we not only did rates per billion kilometres, but we also had a much more accurate rate per million hours used than in our earlier paper. Of course, one limitation is that the people who died and the data for the denominator are 2 different sets of people, but this was the best we could do. So here we have fatalities per billion kilometre by travel mode and sex for people aged 17 to 69 over this 6-year period. For men, when you look at rates by distance, walking in blue was higher fatality rates than cycling in green. Women had slightly lower cycling fatality rates than men on average, but the confidence are very wide once you're looking at specific age groups because the numbers are much smaller. For walking and cycling, it increased with age. For walking, age 45 and over, and cycling 55 and over in men and later in women. And it's especially high for men age 55 and over and women 65 and over. Now, this is fatality rates per million hours spent travelling by men. And you can see that cycling in green and walking in blue increased with age, but it's a very different shape for driving, which is U-shaped in red. We didn't have any data for under 17 because although we have deaths of drivers under 17, there's no reliable denominator data. Here we're looking just at the 17 to 69-year-olds, and our all column is for those aged 17 plus to make it a better comparison. Again, you can see it's higher in men than women. The driving in red is significantly higher than cycling in green for men under 21. But driving is significantly below cycling for men and women aged 30 and over. Driving is greater than men for walking and for women. It's higher than for walking in men and women aged below 30. And here the risk in cycling is for those aged 50 plus for men and 60 plus for women, and for walking for 65 plus in men. But note that the y-axis only goes up to 1 death per million hours travelling. When we look at those aged 70, the y-axis is now up to 3 because the rates are much higher in those aged 70 and over. Interestingly, the rates are separate for men, but they overlap more for women, and there are no significant differences for women aged 70 and over. In this study, unlike our first one, we also looked at the impact of deprivation. And these are fatality rate ratios for the most deprived compared with the least deprived quintile for the same 6 years. And these data, this chart is for time spent travelling. If you look at the paper, you can see the data for distance travelled. And as I say, this is the area deprivation for the residence of the road travel user, not the location of the crash. For all modes, fatality rates are generally higher in more deprived than less deprived people, except for young adults. And we think that's probably because there are more drivers and more car use in the more affluent groups compared with the least affluent. For cycling, the numbers are small because we've now divided into 5 quintiles for each of these age groups. So the confidence intervals are wide, but for children living in deprived areas did have a 2-fold higher fatality rate. For walking, there's a higher fatality rates in more deprived people, except for those aged 17 to 34. And for driving, the data by distance, which I'm not showing you, showed that the fatality rate was higher for the most deprived group for every group under 65. But this chart shows time spent travelling, and here it's only raised for those aged 35 to 64. Now, although we think that this was the best analyses that had been done at this time, there are still limitations. One is the accuracy of the coding. For the external code, an awful lot of data were unspecified location, or what's referred to as a dustbin code. We don't know what it is, or we can't be bothered to work it out, so we'll just put it in that code. So what we did is, if we weren't sure about pedestrians, we excluded them. So our pedestrian data is an underestimate. Whereas for cycling, if we weren't sure, we included it. So for cycling is, if anything, an overestimate. Secondly, type of road. The road injury comparison should ideally be between cyclists or pedestrians and drivers making similar journeys on similar types of roads. But we can't do that. Drivers have lower fatality rates partly because they drive on a safer environment, namely motorways, which is inaccessible to cyclists and pedestrians. The Road Casualties Great Britain 2015 report said that motorways carry around 21% of traffic, but they account for only 6% of fatalities. So when we're using distances or time, we're substantially underestimating fatality rates for drivers on other roads, because the most time spent travelling and the most distance driven are on these safer motorways. So, for example, Department for Transport data from 2012 showed that fatality rates for car occupants were 1.4 per billion vehicle miles for motorways and 6.7, almost 5 times higher, per billion vehicle miles on minor roads. But unfortunately, denominator travel data aren't available by age group and sex, nor by IMD by the type of road. So the comparison between modes is imperfect, as the fatality rates aren't available for age, sex, travel mode, and road type. So if we consider these totals here, the totals for driving are substantial underestimates of the fatality rate for drivers on minor roads where the walking and cycling happens. And if you adjust for that, we don't know how much to adjust for that, but in different years, the fatality rate for drivers overall, without looking at age and sex, on motorways is between 7 and 10 times less than the rate on main roads. So if you made that adjustment, you'd find that really there's not much different at all. The other limitation is that fatality rates are based only on drivers, don't portray the full impact of driving. So we decided to do a full account, including deaths to all other road users in fatal crashes. And this work was led by Sean Scholes. We found that most deaths in car crashes were to non-drivers, and that applied especially for young male drivers, which, as you may remember, they had the highest fatality rate. And the deaths were to passengers and to other road users. Fatality rates based on all road users were higher for driving than for cycling, but the higher rates of deaths for cyclists themselves co-occur with lower rates for other road users. So this is the fatalities for the person in charge of the vehicle, i.e. the driver or the cyclist. Road travel deaths have fallen over time. We've got 3 different 3-year time periods here. But the patterns or inequalities are similar in the time periods. So males on the left, females over on the right, with the 3 different time. Dark for car crashes, pale for cycle crashes. And fatality rates and by age and sex were mostly higher for cyclists than drivers, other than particularly in the earlier times for young males. That's what you saw before with a slightly shorter time period. Now, this is the fatality rate per million hours travelled for third-party road users by travel mode. And here you can see that the death rates of other road users for drivers were much higher than for cyclists, particularly for men, also for women. And this is the fatalities for all road users. And again, you can see that it has fallen over time, but it's fallen over time, but you can see even in the most recent data, it was higher for drivers under 26 than it was for the cyclists. So males aged below 25 and under are safer when they cycle than drive, and so are the rest of us. And as with the previous studies, the rates are underestimated for driving on local roads because the greatest distances and times spent travelling are on the relatively safer motorways and A roads. What I'm going to show you next is studies by other researchers. First, Rollinson and colleagues in Great Britain in 1989 to 2009. Now here their denominator is trips rather than distance or time, so this does reduce the skew for the long journeys made by car on safer roads. There's a similar U-shape for drivers and car passengers, but a different shape and much higher rates in older people for pedestrian fatalities. The first of 2 studies I found from Spain, Catalonia 2004 to 2008. On the left are serious injuries, on the right are fatalities, men with circles, women with triangles. Among child pedestrians and young drivers, the higher rates are very visible for men compared with women. Age 65 and over, there's a higher injury risk for women than for men. But the death rates are always higher in men than in women. And then the second study in Andalusia, KSI is killed or seriously injured. Here, the upper set of charts are for urban roads and the lower ones for rural roads. What's important is to notice the very different y-axis numbers. Motorcycles, far more than pedestrians, which are a little bit more for serious and fatal injuries on urban roads and much more on rural roads. And overall, for each mode, the KSI rate is much higher on rural than urban roads. But what this and the previous and the studies all show the difference by age and the difference by sex that I showed you with our data. Now, Rachel Aldred and her colleagues looked at the risk on other road users. This one is the impact on actual road users themselves. The top major roads bottom minor, left for rural, right for urban. The horizontal lines are estimates from their data, and the vertical bars are the 90% confidence intervals from their regression model. Females in turquoise and orange, males in purple and pink. They haven't adjusted for age, which you'll realise is important. It's difficult to read. The x-axis are the different travel modes: car and taxi, van, lorry, which had amongst the highest rates, motorcycle, which had high rates in some, again in most, and bus, which also had high rates. It's important to note that these are vehicle kilometres, not passenger kilometres. If you adjusted the bus for passenger kilometres, the rates would be lower. And this is the same chart, but this time showing the risks posed to other road users. So again, bus is higher than it would be if you used passenger kilometres. And again, when they analyze the data by sex, it's higher for males than for females. Not shown on this chart. Now back to Great Britain and recent data. There were 340 billion vehicle miles travelled. So that does exclude walking and cycling on traffic-free routes. And that's a return to the 2019 pre-COVID levels. 4.7 road deaths per billion vehicle miles, but 3/4 of fatalities and 3/5 of injuries of any severity were amongst males. There's been a downward trend for many decades, but not so much in the last 15 years, that you can see the 2020 dip. And that's even more noticeable here, where you look at it, road travel fatalities per billion miles travelled by road type, user type, and you can see this big drop in pedestrian deaths in 2020, and interestingly, an increase in car occupants. Now, all of them are lower than they were 10 years ago, although for motorcycles it went up before it came down. If you look at a comparison of 2011, when near the end of our travel period, and 2024, there's been a dramatic fall in all road travel injuries. There's been a fall in fatalities, but actually a rise in serious non-fatal injuries. And there's also been a fall in each group, in car occupants from 883 to 692, pedestrians 453 to 409, motorcyclists have fallen, and cyclists have fallen, and then smaller numbers in the other travel modes. Though that was numbers, this is deaths per billion miles. As you know, I prefer rates to numbers. And here, motorcyclists have way more, an order of magnitude higher than anybody else, and a long way behind are pedestrians and then pedal cyclists. Now, this is other road users killed. I don't know whether whether the Department for Transport started including the injury and death rate by age and gender because of the work we did, and I don't know whether they more recently started looking at deaths of other road users because of the work that we did. Who knows? Anyway, they do now report this. Here, other road users killed, and this is excluding vehicle 2 or 3 plus 3 vehicles, because they didn't know whose fault it was. So you can see cars, and then way below that, heavy and light goods vehicles. And if you compare the fatalities of road numbers, so these are cars are highest both for their own occupants and for other people. And then on the left, we've got other road users killed by billion passenger miles. And on the right, we've got fatalities by travel mode. So motorcyclists kill 11 of themselves 11 times as often as they kill somebody else. Cars had killed 2 occupants and 1.6 other road users per billion passenger miles. And to put them on the same scale, the actual risk for cycling is very small. 24 deaths per billion miles in 2023 means that a cyclist who rode about 1,500 kilometres a year might have 1 fatality every 44,444 years. And the risk of collision leading to hospital admission is higher, but it's still less than 1 admission for every 1.5 million kilometres cycled. Britain is doing very well compared with most other countries. We're 4th on this scale. Those who want to can look at these slides and get the link for mortality elsewhere in the world. So to conclude, overall fatality risk is similar for cyclists, pedestrians and drivers. The risk is higher in men than women and in younger males than females. It's particularly high for young male drivers, and the risks for everybody, including themselves, are lower if young men cycle rather than drive. And not making like-for-like comparisons maintains a false impression of the risk of cycling. Thank you.